first presenter, which is Dr. Mike Icha, a consultant gynecologist with the Federal Medical Center, Jalingo, which will be giving us overview of infertility and evaluation of infertile couples. Before he starts, I will encourage us to mute our mics so that we'll have less interference. And after the presentation, if you have questions, we can use the reaction to raise our hand so that we'll have opportunity to ask questions so that we'll be more organized. Over to you, Dr. Mike Icha.
I'll go back in 5 minutes.
Good afternoon. Can you hear me?
Yes, we can hear you, but you need to increase your voice.
Okay, thank you very much, sir. Can you hear me better now?
It's better. It's better now.
Yes, we can hear you.
Okay. Good afternoon, senior colleagues and colleagues, ladies and gentlemen. My name is Dr. Mike Icha. I work at the Federal Medical Center in Jalingo. I want to thank the NMA for the honor to do this presentation. So I'll proceed right away. And the topic is overview of infertility and evaluation of the infertile couple. All right, so I'm going to address it using this outline. Infertility is a common reason for gynecological consultations worldwide. And it is estimated that about 10 to 20% of couples have difficulty conceiving. And in our setting, it contributes to a significant proportion of the workload of the gynecologist, estimated to be up to 60 to 80%. And infertility is associated with severe emotional and social distress for the couples, with significant psychosocial morbidity. And then women suffer the most, as most times the male factor is typically not recognized. Now this suffering assumes a higher proportion in societies like ours, where procreation is accorded greater cultural and social value. For instance, infertility is a socially acceptable basis for divorce by the husband in some settings. So women usually are the first to present for evaluation. Management can be challenging in developing countries, and there's a large scale of misinformation and myths about the causes of infertility. Some couples attribute their infertility to witches and sorcery, witchcraft, other things like annoyance of the gods, and so on and so forth. And many also consult non-medical treatment as first line before they seek orthodox help when these fail. And even when they come to facilities like ours, they tend to doctor shop from one doctor to the other. And many times, combinations of both orthodox and non-orthodox methods of solution are present. Now, in our setting also, there's a lack of a well-designed protocols with haphazard manner of investigations and treatments. This, in addition to the cost of infertility treatment and the unfavorable economic climate, is also a problem for us. Infertility is defined as the inability to conceive within a period of unprotected and regular sexual intercourse, usually a year, according to the WHO. And this arises because of an impairment of a person's capability to reproduce, either as an individual or with his or her partner. The term infertility is synonymous with subfertility, and they are used interchangeably. But this is different from sterility, which is a related term. But sterility, on the other hand, means an absolute defect preventing conception. That is to say that the individual lacks the capacity to reproduce For instance, women who don't have a uterus will be said to be sterile. Other associated important terms that should be defined include fecundability, which is the probability of misconception per cycle attempted. And it is said to be 20 to 25% in normal fertile couples. And then the other terminology is fecundity, which is the probability of achieving a live birth in one menstrual cycle. Infertility may be primary or secondary. It is primary when the woman has never conceived, and secondary when the woman has previously conceived, irrespective of outcome. And the primary form is the commoner form in developed countries, mainly due to ovulatory disorders, while secondary infertility is commoner in our own setting as a result of tubal factors. Either of these two can be said to be unexplained when there is no demonstrable cause of infertility after an assessment for tubal, ovulatory, and male factors have been done. So let's look at the epidemiology. I'd said earlier that about 10 to 20% of couples of reproductive age will present with infertility, generally worldwide. And in the UK, for instance, 1 out of every 7 couples are infertile. Global estimates are 48.5 million couples with primary infertility and 29.3 million couples with secondary infertility. All right, but in our setting, the prevalence may be higher than this. It's said to be about 20 to 46% in sub-Saharan Africa. In Nigeria, 1/5 of every couple have difficulty with conception. And there is an important epidemiological finding of high rates of infertility in regions with high fertility rates in sub-Saharan Africa. And indeed, an infertility belt has been described in Africa that stretches from west to east of Africa and includes several countries with high fertility rates and high prevalence of infertility. This includes Nigeria, Cameroon, and the rest of them. And this is described as the demographic paradox of barrenness amidst plenty. Now, like I had said, in the tropics, infertility is largely secondary from tubal damage as a result of infections. And infections like sexually transmitted infections, post-abortal and puerperal sepsis, in contrast to what obtains in developed countries, where ovulatory and male factors are the main findings. So, with respect to the causal distribution of infertility in couples, about 30 to 40% are due to male factors. Similar percentage for female factors. 10 to 20% are due to both the male and the female, while 5 to 10% may be unexplained. Let's look at the etiology briefly. Now, the etiology of infertility may arise from female factors or male factors. And male factors account for 30 to 40%. While female factors may be tuboperitoneal factors, ovulatory factors, uterine factors or uterine pathologies, and cervical factors. Tuboperitoneal factors, this is the subset of infertility that is due to the female factors now. Tuboperitoneal factors account for 30 to 40% of all female infertility. Ovulatory factors, 30 to 40%, uterine pathologies, 15%, and cervical factors, 5 to 10%. These are all in general terms. So, briefly, I know the physiology of natural conception is that the hypothalamo-pituitary, ovarian, and uterine axis in the female has to be intact, with hypothalamic hormones produced, act on the pituitary to produce the gonadotrophins, which will then act on the ovary to generate estrogen and progesterone. As well as, well, the gonadotrophins act on the ovary for 2 processes, mainly steroidogenesis and for folliculogenesis. So the production of mature ova that are released at fertilization, and then steroid hormones that prime the uterus and prepare it for fertilization of the ovum. And all of this has to be intact. The tube has to be patent to pick up the fertilized, the ovulated ovum, and then after fertilization, the uterus must be receptive to allow for implantation of the fertilized ovum. And then in the male, similarly, there's also a hypothalamo-pituitary testicular axis for the production of mature spermatozoa as well as male hormones. And the male, in addition, should have the capacity to deposit semen in the female genital tract during coitus. So this background is helpful in understanding the factors involved when we talk about the etiology of infertility. So for tuboperitoneal disease, causes of infertility or tuboperitoneal disease that could result in infertility includes infections like sexually transmitted infections, pelvic inflammatory disease, post-abortal and puerperal sepsis, and then endometriosis in the female also can cause tuboperitoneal disease that can result in infertility. Both infections and endometriosis will result in adhesions. Adhesions can also arise from other causes, including pelvic and abdominal surgeries. And then tuberculosis also of the female genital tract can result in infertility due to tubal disease. Then for female factor infertility, that is, for ovulatory disorders now, the WHO has classified the disorders of ovulation into 3 groups. Group 1 accounting for 10%. This classification is based on the levels of follicle-stimulating hormone, luteinizing hormone, and estradiol. Group 1 disorders affect about 10% of, or account for about 10% of ovulatory disorders. And they are mainly hypothalamo-pituitary dysfunction, either from hypothalamic amenorrhea, which occurs in women who exercise excessively, then excessive weight loss, and in obese women, and people with dietary disorders like bulimia nervosa, as well as anorexia nervosa. Then chronic illnesses and stress can also result in this group of ovulatory dysfunction. Then other conditions like diseases and infections and infiltrations involving the CNS will cause hypogonadotrophic hypogonadism. These conditions like Kalman syndromes, CNS tumors, and then exposure to chemotherapy and radiotherapy, as well as drugs such as corticoids and narcotics. Then in this group also are hypopituitary disorders like Sheehan syndrome, that is pituitary necrosis arising from postpartum hemorrhage, resulting in pan-hypopituitarism, and then also hyperprolactinemia, either from micro or macroadenomas. All of these will cause ovulatory dysfunction. In the second group, which accounts for the majority of women with ovulatory disorders, about 85%, the follicle-stimulating hormone and may be low or normal, then luteinizing hormone may be normal or high, while you could have normal levels of estradiol. And this mainly is as a result of hypothalamo-pituitary ovarian dysfunction this time. And the main component of this is polycystic ovarian syndrome. Then others are other causes of hyperandrogenism. And the last group, characterized by high follicle-stimulating hormones and luteinizing hormone, low estradiol levels, are women with ovarian failure or insufficiency, either from bilateral oophorectomy, Turner syndrome, chemoradiation, or to the ovaries. This makes up about 5% of ovulatory dysfunction, according to this classification. However, there are other things that may cause ovulatory dysfunction, like endocrinopathies, thyroid disease, adrenal disease in women, and then diabetes, especially when it is uncontrolled. The uterine factors accounting for infertility could arise from uterine fibroids. The relationship between fibroids and infertility is still not very clear. Whether fibroids are causal or casual in women with infertility is still an area of debate. However, we've observed women who have infertility, who have fibroids that get pregnant, and then women also who have fibroids but fail to get pregnant, and when the fibroids are removed, they eventually get pregnant. So other uterine factors are intrauterine synechia from vacillus curettage, that is Ashman syndrome, or synechia from sepsis, either puerperal or post-abortal. Then cervical factors, which account for just about 5% of female factor infertility, may be due to alterations of the cervical mucus, either from previous operations, dilatation and curettage, or for congenital anomalies as rises from in utero diastase-to-bestial exposure. And then the other aspect is mucus hostility with the production of anti-sperm antibodies by the woman. For male factor infertility, the etiology is broadly classified into pre-testicular, testicular, and post-testicular causes. Pre-testicular causes, these are mainly endocrine, that is before the level of the testes usually. So the male, we also have Kallmann syndrome, pituitary failure, then hyperprolactinemia from several causes, then exogenous androgen use, thyroid and adrenal disorders can also cause this failure of men to be fertile. Then for testicular causes, there are causes of abnormal spermatogenesis. Men that have had mumps or otitis with damage to the testes, men with undescended testes as well. Chromosomal anomalies affecting spermatogenesis like infertile syndrome, chemical or radiation exposure of the testes, varicocele, and then traumatic injury to the testes. The post-testicular causes of male infertility includes both abnormal motility, anatomical disorders, and sexual and erectile dysfunction. That is to say, the spermatozoa production is normal, but the transit across the male genitalia, and as well as the position in the female genital tract, is not optimal. So abnormal motility can arise from varicocele anti-sperm antibodies in the man, as well as absent cilium or cartilaginous syndrome. Anatomical disorders like congenital absence of the vas deferens, associated usually with cystic fibrosis, obstruction of the vas deferens as a result of infections, which is commoner in our environment, then congenital anomalies of the ejaculatory system, and as well as post-surgical damage to the vas deferens. Then sexual and ejaculatory dysfunction, such as retrograde ejaculation, impotence, and decreased libido, can also cause male infertility. It's a diagram that tries to depict some of the things I've mentioned at the various levels where they occur. But there are other important factors that are associated with infertility that I've not mentioned, like the age of the woman. The age of the woman is a very important factor in regards to fertility. Then there are several other factors like delayed childbearing, which will mean that many women will seek to have children when they are over the age of 35 years, because fertility declines after 35 from 10% in women with less than 30 years of age. That is infertility now. The prevalence of infertility in this woman less than 30 years of age is 10%. And it declines to, infertility increases to 30% in women who are more than 35 years of age, and up to 60% in women who are more than 40 years of age. Contraception is said to confer protection on fertility. And cultural practices and marriage and sexual customs early marriage, late marriages, number of sexual partners that can cause increased risk of sexually transmitted infection, female genital mutilation. All of this can cause risk of infections. Then consanguineous marriages can result in genetic diseases that may result in infertility. Then occupational and environmental hazards, especially in the male, exposure to heat, hydrocarbons, and heavy metals. Men with long distance driving and all of that in which the testis is said to be exposed to heat, can reduce or decrease fertility. There's socioeconomic factors like poverty, smoking, and alcohol abuse can also is also associated with causation of infertility. Now, how do we evaluate the infertile couple? The contemporary approach to evaluation and management of infertility is that of active management. The principles in evaluation and management include taking a critical history, relevant physical examination, directed investigations, and treatment of patients. Patients should be individualized, treated as individuals, the couple treated together, and this treatment should involve treatment of the cause of infertility. What are the goals of evaluation of the infertile couple? First is to determine the likely cause or probable cause of infertility, and then to provide accurate information to the couple about the prognosis, and also to provide counseling, support, and education during evaluation. And lastly, to provide guidance regarding options of treatments. Now, some of the important things that should be borne in mind include, during evaluation, include assessing the couple together. However, women are usually the first to present, so one can proceed with evaluation of the woman at that time. And then the evaluation will require privacy and sufficient clinical time. And then counseling and psychological support is key during evaluation and treatment, irrespective of the outcome of procedures. Each stage in the investigation and treatment should be explained to the couple, and the adoption of simple and systematic evidence-based protocols are better, with stepwise manner of planning and execution. Emphasis should be on investigations that correlate more directly with pregnancy. And that is to say that there is no room for wasteful, general, or expensive investigations without focus. And then treatment should ideally be complete. Excuse me, please. Investigations should ideally be completed before treatment. And all of these help to reduce time and cost. And this helps to also ameliorate the emotional trauma that couples with infertility experience. So in the history, the couple, when the couple presents, or when the woman presents, it's important to determine the age of both partners. Age is said to be the age of the woman is said to be the single most important determinant of a couple's fertility. The duration of infertility, which may give an indication of the severity. Coital history, is coitus adequate and satisfactory? Adequate coitus is coitus at least 3 times a week. And then whether there's a history of coital dysfunction, whether there has been a previous pregnancy in the relationship. And then further, an understanding by the couple of what the fertile period of the woman is, then history of other possible etiologies, any previous orthodox treatment and investigations that have been given or that have been received, as well as traditional medication, and then any previous results should be reviewed during this process. Further history in the woman will involve menstrual history to give us an indication of whether ovulation is occurring or not. And then this also may suggest whether there is fibroids, chronic pelvic inflammatory disease, or adenomyosis. It is said that in 95% of women with a regular menstrual cycle, every 23 to 35 days, ovulate. That is, ovulation occurs in this percentage of women who menstruate regularly. So when a woman is menstruating regularly, she's likely to be ovulating. So other history include gynecological and contraceptive history, history of all previous pregnancies, medical and surgical history, any chronic medical disorders, and then previous surgeries that the woman may have had. Further evaluation of the male, history of genital tract infections, previous treatment for testicular maldeasance, genital tract operations, concurrent or past medical conditions like diabetes, renal disease, thyroid disorders, and the use of medications that may suppress spermatogenesis, like nitrofurantoin and anabolic steroids. And still also in the man, behavioral and occupational hazards, like I mentioned earlier, long distance drivers, soldiers on special duties, who spend long times away from home, and then men who are at increased risk of multiple sexual partners that can result in STIs with blockage of the vas deferens. There's history of sexual and erectile dysfunction, as well as social history involving smoking, alcohol, and use of other drugs. A physical examination in the patients as directed by findings in the histories, actually relevant, directed physical examination. And it starts with general observations of the couple as the couple walks into the consulting room, the appearance of both the man and the woman, if we have a chance to have them presented together, or the woman first and subsequently the man, general nutritional state, and whether they have, either of the couples have obesity, any history that may suggest complications arising from the problem that they have in terms of discord and despondency, discord between the couple and so on, can be picked up by generally observing the patients. Then this observation can also help us, find out patients that may have hypothyroidism, excessive sweating, slurred speech for hypothyroidism, women that have short stocky statures with web neck may have Turner syndrome, and people with androgen excess, hirsutism, alopecia, thinning, men with gynocoid habitus, and so on. And then more specific examination in the woman will be general and a systematic examination. General examination should include nutritional status, general well-being, the weight and height and body mass index, whether she has hirsutism, and so on. And then also the blood pressure should be checked, breast may be examined. If there is a history of galacturia, may examine also for masses and to determine the internal stage of the breast. Then the neck examination for the goiter may also be performed. Then abdominal examination will involve examining for the general appearance of the abdomen, presence of pubic hair and the pattern. Is it a male pattern, a woman, which may suggest androgen excess, presence of surgical scars, and the manner of their healing. Is it by primary or secondary intention? Scars that are hypertrophic may suggest intraperitoneal adhesions from difficult surgery or from postoperative morbidity following surgery, and so on. And then examination for masses like uterine fibroids, ovarian tumors. Then pelvic examination with the speculum or also digital. Examination of the external genitalia, is there clitoral enlargement, is vaginal blind ending, any features of infection like foul smelling discharge, the presence of cervical polyps. The uterus size should be assessed. A small atrophic uterus may suggest hypoestrogenism, and the uterus could be enlarged with myomas and adenomyosis. And then also examination of the adnexia for tenderness and any other pathology, as well as the patch of Douglas for nodularity and uterosacral nodularity, which may suggest the presence of endometriosis. And this opportunity can be taken to also take swabs for microscopic culture and sensitivity. Now, examination of the male. Now, usually a normal seminal fluid analysis excludes significant male factor, actually. And so some authorities will say that the male should be examined by the gynecologist when the seminal fluid analysis is abnormal. However, examination should be directed. If it's indicated from the history, it should be performed and could also be general and systemic. And then examination generally for weight, height, body build, whether the man has obesity. The neck can be examined for goiter, breast for gynecomastia. The blood pressure can be checked. Does he have hypertension? Then for abdominal examination, what is the hair pattern? The man with a female pubic hair pattern, presence of surgical scars, masses in the abdomen. And then genitalia can also be examined. What is the size of the penis? Are there scars in the groin? And then what's the location of the urethral meatus? Scrotum and testis should be examined for any induration and along the epididymis or the spermatic cord, which may suggest inflammation with subsequent obstruction. And then examination for a varicocele, that is sort of dilatation of the pampiniform plexus of veins. And then the testis, the scrotum should be examined for the presence of the testis. Are the testes present, or is there maldescence with arrest of descent of the testis along this course? Then the testicular volume can be assessed or size using a Prada oxidometer. The normal volume of the testis is 15 to 35 mils with an average of 18 mils. Now, a few things about investigations. What is the approach to investigation, and when do we investigate the couple? The couple should be investigated concurrently, but like I said, the woman, it could start with the woman since they are the first to present. And then investigation for infertility generally should start 1 year. That is after a year of inability to conceive. However, investigation can commence earlier. Let's say after 6 months in certain groups of women, in women who are already advanced in age, and in couples who have a history of problems that suggest impaired fertility. Such histories include histories in the man of STDs, mucoitis, and surgery for undescended testes, hydrocele, chemotherapy, and radiation therapy. In the woman with delayed puberty, you don't have to wait until it is 1 year before you start evaluating. People with previous history of pelvic inflammatory disease, women with previous history of puerperal or post-abortal sepsis, with surgery, previous surgeries like myomectomies, appendectomies, cystectomies, and then even laparotomy for peritonitis. In this category of people, an investigation can commence within a year or not after a year. And then sometimes the patient may also request for earlier investigation. So what are the investigations that we usually perform? In the male assessment, it's either male assessment or female assessment. And in the female, assessment of tubal patency, ovulation assessments, uterine and cervical assessment. Tubal patency tests include hysterosalpingography, HSG, which traditionally has been advocated as first-line test for tubal patency. And others are laparoscopy and dye tests. Now, laparoscopy is the procedure of choice when evaluation of the pelvis is also required. That is laparoscopy and dye test. Generally, it is said to be complementary to HSG. But laparoscopy is also considered many times as the gold standard. And in people with tubal patency demonstrable by HSG, 94% of them are confirmed at laparoscopy. This is just a picture of an image of HSG image of, it shows bilateral distal tubal blood in these patients. These are some images that we can see at laparoscopy. This is Fitzhugh-Curtis syndrome, which suggests it's a feature that is found in chronic pelvic inflammatory disease. These are intraperitoneal adhesions. This is, there's no dye spillage here as a result of this this looks like a hydrosalpinx, and so on and so forth. Another test of tubal patency includes hysterosalpingocontrast sonography, what is called HICOSY. It has similar diagnostic accuracy with HSG, and the added advantage that it avoids radiation because it's done with ultrasound. Then the chlamydia antibody tests, which is also a cheap test. It's maybe cheaper, it's less invasive, and can be performed at any time of the cycle. There are still other tests that may be performed depending on the need where facilities are available, include trans-cervical falloposcopy, selective sapingography, fertiloscopy, sapingoscopy, and microsapingoscopy. Excuse me. Uterine assessment, pelvic ultrasound scan assesses the uterine wall, the endometrial cavity, and the adnexa. And then one can also do saline infusion sonography. Then HICOC also assesses the uterine cavity to some extent. And then hysteroscopy, not routinely performed, but where clinically indicated for the evaluation and treatment of abnormalities identified by less invasive methods. For instance, patients with intrauterine synechia, Asherman syndrome benefit from hysteroscopy. And sometimes it may be a requirement before proceeding to, or most times really, for artificial reproductive technology. And what are the tests of ovulation? Like I've mentioned, regular menstruation is strongly suggestive of ovulation. And then, however, tests should be performed to confirm ovulation. And the major tests are mid-luteal phase serum progesterone. When it's greater than 5 nanograms per mil or 13 nanomoles per liter, shows that ovulation has occurred. And the other modality is follicular tracking using transvaginal ultrasound scan. Other tests that are not very commonly used include serial measurements of serum luteinizing hormone, and then baseline basal body temperature assessment and cervical mucus testing. But related to ovulation, there are other assessments that are important, like assessment of ovarian reserve. And this involves measurement of follicle-stimulating hormone, as in the early follicular phase, intrafollicular count, as well as anti-mullerian hormone. This will help guide treatments and also triaging of patients in terms of what treatment will be most appropriate for them. And the predictors of poor ovarian reserve, according to the National Institute of Care and Health Excellence in the UK, as also present for each of the tests performed. Other tests, as directed by previous evaluation, will include serum prolactin if there is history of hyperprolactinemia, and be further evaluated for pituitary adenomas with skull X-ray and CT scan, androgen, thyroid function test, and karyotyping. Now, let's go to male assessment. Seminal fluid analysis. A normal seminal fluid analysis actually demonstrates that male infertility, or results of seminal fluid analysis demonstrates or determines whether male infertility exists or not to a very large extent. And but it should be performed according to recognized WHO methodology, and including some of the guidelines like abstinence of the male for 3 to 5 days, awareness of smoking, and the manner of collection and analysis. What are the normal reference parameters? These are the reference parameters that we currently use from the WHO manual that was released in 2010. The highlights are the concentration is 15 million per mil, total sperm count 9 million per ejaculate, total motility of 40% with 32% progressive motility, and then morphology of at least 4%, at least, for each of these parameters. Now, abnormal seminal fluid analysis should be repeated to confirm the result. And this may be done 2 to 3 months after the initial test in order to allow time for the process of spermatogenesis to occur. These seminal abnormalities can be azoospermia, absence of sperm in the ejaculate, oligozoospermia, teratozospermia, astenospermia, a combination of these. One of the common combinations is oligoastenoteratozospermia, which we call Oates syndrome. Then aspermia when there is no ejaculate. Other male assessments that can be performed depending on what was found on history, examination, and seminal fluid analysis include hormonal profile of the male. In patients with azoospermia, in men with azoospermia, it's important to determine whether this azoospermia is obstructive or as a result of failure of the testes to produce spermatozoa. So when a hormonal assay is done, this may help in this regard. Assessment of prolactin as well. And then where retrograde ejaculation is suspected, post-ejaculate urine sperm pelleting and examination can help concentrate the sperm to rule out azoospermia and to also confirm the diagnosis as retrograde ejaculation. There is semen, but it is the man ejaculates into the urine. Other tests are semen culture, imaging, testicular and scrotal scans, the performance of a karyotype, and also sometimes testicular biopsy. The other investigations are the postcoital tests. Now, this test assesses both cervical factor in the woman as well as male factor in the male, and can be used in men who refuse to present for evaluation. And it is usually done at mid-cycle within 9 to 24 hours of intercourse. It assesses the quality and quantity of the cervical mucus and the presence of a number of motile spermatozoa within the mucus. So a normal test demonstrates abundant, clear, watery, relatively acellular cervical mucus with at least 5 motile sperm. Sorry for that typographical error. Present per high power field. But this test is sort of difficult because most times it's improperly performed or not well timed. And the commonest cause of abnormal results is an improperly performed test. Now, what are the diagnostic or the investigative modalities that are most important in patients being evaluated for infertility? Because investigations generally have been classified by the European Society for Human Reproduction and Embryology into tests that have an established correlation with pregnancy, and then tests which are not consistently correlated with pregnancy, and tests which seem not to correlate with pregnancy. And of these tests, the tests that have an established correlation with pregnancy are the seminal fluid analysis, the hysterosalpingography, or laparoscopy, and mid-luteal phase progesterone. Now, unexplained infertility. A couple may say to have unexplained infertility when there is no discernible cause of the infertility after a comprehensive tubal assessment, an assessment of ovulation function, and a seminal fluid analysis, and usually after 2 years of regular unprotected sexual intercourse. It's important also that evaluation of the couple is done concurrently whenever investigating patients for infertility. Now, infertility evaluation can be performed, that is, the investigations for infertility can be performed or completed in a single month or in one menstrual cycle. And the results provided can be used to guide treatment in the succeeding months. History and examination can be done on the days preceding the onset of menstruation, and then the seminal fluid analysis can be done on day 1. The idea is to do it during menstruation when the man is expected to abstain and not have coitus with his partner. And then the hormonal assay in the woman can usually be performed on days 2 to 3. Idea is to do them in the follicular phase of the menstrual cycle. HSG can be done on days 6 to 10. And the idea here is to do it after menstruation, but before the expected time of ovulation. While a postcoital test can be done on the 14th day, and a progesterone assay done on the 21st day of a 28-day cycle. The idea is to do it when it's peak, when it has reached its peak values in the mid-luteal phase. Laparoscopy can also be done around that time. Now, so these evaluations, important evaluations, can be done within one menstrual cycle in a woman who is menstruating regularly. And this is the concept of active evaluation and management of infertility. And it has a lot of advantages. It helps to reduce emotional and psychological distress in the couples. It enlists their confidence, and it decreases the likelihood of them seeking alternative remedies. And even in women with cycles that are not regular, all of this can also be done within a month so that management treatment can commence in the subsequent months. So treatment depends on the identified cause. I know there's going to be another presentation on treatment. This is just an overview with respect to treatment. Could be multimodal or multidisciplinary. Counseling and psychotherapy is important. Modalities include non-pharmacologic, pharmacologic methods, and then maybe surgical methods as well, and assisted reproductive technology. And surrogacy and adoption are also important in treatments for patients who are unable to conceive with all the measures that we have. So prevention is important. Prevention is key. They say prevention is better than cure. Prevention of infertility can be primary, secondary, or tertiary at those three levels, primary, secondary, or tertiary levels, and involve things like elimination of unsafe abortions, early recognition and treatment of post-abortion complications, improving maternal and child health programs, hygienic obstetric procedures, treatment of puerperal infections, adequate and prompt treatment of pelvic inflammatory disease, and then high quality and accessible family planning services to prevent sexually transmitted infections and unwanted pregnancies. So in conclusion, infertility remains a major public health challenge, and it occupies a major part of gynecological consultations in our environment. A practical approach to evaluation using a logical, systematic series of evidence-based steps to assess sperm quality, ovulatory status, and tubal patency is advocated, usually performed within one menstrual cycle. Counseling is also key in evaluation and treatment. Thank you for your time.
Thank you, Dr. Mike, for your lucid and elaborate presentation. We appreciate you for that. We know infertility is actually a wide area, and I don't envy anybody that is presenting it. In order for us to manage time, I think we'll take the next presentation, we'll take the three presentations since they are related, so that we'll take the comment and questions at the same time. Do we agree? Hello?
Yeah. Yes, carry.
Yes, carry.
Yes.
Go
ahead, yeah.
Oh, okay. So we'll now take the next presentation, which is treatment modalities in infertility and assisted reproductive technique. Will be taken by Dr. Nelson Vincent, who is a clinical embryologist and assisted reproductive technology specialist from Taraba State Specialist Hospital, Jalingo. Over to you, Dr. Nelson Vincent. I think Dr. Mike can unshare his screen so that Dr. Nelson can share his own screen.
Good evening, senior colleagues and colleagues. Permit me to stand on the existing protocol.
Yes, we can hear you.
Yeah, hello, am I audible enough? All right. Yeah, the topic before us, as Riley said, treatment modalities in infertility and assisted reproductive technology. Okay, this is the outline I'm going to take. And as a matter of introduction, the treatment of infertility depends on the suspected cause of the infertility, the affordability of the treatment, that's the affordability to the couples, the availability of facilities, and the ethical acceptabilities. We have some form of treatment that may not be acceptable to some patients. We have seen cases where you offer a treatment protocol and the patient tells you, it's against my faith, my tradition, or so, as we shall see later. A definitive diagnosis of infertility is central in instituting the right and cost-effective form of treatment. Because by the time a clear-cut diagnosis is not met, you may end up beating about the bush and spending patients' money and wasting patients' time, especially if the woman is of age, maybe above 35 years. Making of these diagnoses can be very difficult, especially in places where the resources are limited. And that's why a fertility center is required to treat infertility cases. Or if it's a center where other services are rendered, like the tertiary institutions we have in the state, the Federal Medical Center and the State Specialist Hospital, a fertility unit is expected in the O&G department to handle fertility cases. Because making a diagnosis from the first presenter, of course, we saw what it takes to make a definitive diagnosis. It takes a whole lot of time. You can take more than an hour attending to a single case. So it will be difficult to mix that with other cases. So the basic services provided for an infertile couple: education on infertility, the causes and the prevention. That's already covered by the first presenter. Conduct appropriate diagnostic workup, that has been covered. Then offer information on treatment options and provide resources for counseling and emotional support. So the advice that will be given, that's initial advice to people concerned about delays in conception. Of course, we have to talk to them, people who are concerned about whether they will have a child or not. This could be people who are planning to get married, or people who are just newly married, or people who are married and waited for like 1-2 years, there's no pregnancy and they are concerned, they are worried. We have had cases where singles come to gynae department, O&G department, or to fertility clinics to find out if they could conceive for the female or for the male, if they could father a child. So you give them some advice on recreational drugs, like smoking, cigarettes, and all those things. Weight loss for those who are obese. And this obesity is not just on men, or on the women, but for the men too. Obese men also could have issues with fertility. Obesity is one of the causes of sperm DNA fragmentation, which will affect fertility. Extreme sports, like distance cycling, marathon race, especially for women, those who exercise excessively, men who engage in long distance cycling, the testicles may be under continuous pressure, and that will affect spermatogenesis. And also increase anti-sperm antibody because of micro-injury to the testicles, and will lead to a release to break the sperm-testis barrier. Coital frequency, it's very important too. We have people who are planning to get pregnant. The husband is working in Lagos, the wife is in Jalingo, and they tell you we have been married for 5 years and there's no pregnancy. So they need to know that coital frequency is important in helping them get pregnant, helping the woman get pregnant. patients on routine medication. We have patients who are on some medications that could affect fertility. So when the patient comes, as you plug the patient, you have to find out the patient's medication. We have some anticonvulsants, some antihypertensives, antipsychotics, and you find out the patient is on cancer chemotherapy. We have some patients being treated for cancer that you will not know until they tell you. They look healthy, they look fine until they tell you. So they may not volunteer the information. You have to ask. Then antibiotics for PID and other things, otitis, epididymia otitis, antioxidants to boost spermatogenesis, and other adjuvant therapies should also be prescribed accordingly, and they should not also be abused. Sometimes the drugs are abused. I've seen cases where patients are placed on antioxidants for a prolonged time. Studies show that antioxidants exceeding 3 months may not really be needed again. Think of a definitive treatment. Yeah, I will talk a little about unexplained infertility because it's quite common, not really common, but we tend to see them more because of lack of diagnostic facilities. So we tend to classify them under unexplained infertility or infertility of unknown cause. The prevalence is up to 25 to 30%, and this prevalence is fewer. The fewer the investigations, the higher the diagnosis of unexplained infertility. When you do limited investigations, let's say a couple come, you do HSG, for tubal patency, you do semen analysis, you feel these are the 2 factors that will result to pregnancy, and you didn't do other things, you may say, you hear cases, patient telling you, they have checked us, done everything, and nothing has been found. So we are healthy, and yet we don't have a child. And they say it's infertility of unknown cause. No, sometimes it's limited investigation. So when laparoscopy is done, laparoscopy is key in the diagnosis and even treatment of infertility. When laparoscopy is done, this unexplained infertility or infertility of unknown cause, as we may call it, reduces to 10 to 20%. And that is when laparoscopy is not done, rather, when it is not done. And of course, we know that in our state, Taraba state, we don't do laparoscopy. Then less than 10% when laparoscopy is done, the prevalence reduces with advanced investigation. Where the couple evaluation, sorry, let me take this again. Where the couple's evaluation completes, okay, you ask whether the couple's evaluation were completed according to standards, or were the tests conducted correctly, or were the results interpreted correctly. You know, sometimes we see patients, personally I've seen patients where the tests were not well done. One of the tests that is actually being wrongly done in most cases is semen analysis. Semen analysis is quite wrongly done in most instances, and even in our state. We are currently conducting a study on the semen analysis standardization in Nigeria, and using Adamawa states, not precisely Jimeta, Yola, and Taraba states as our study area, collecting data from labs and scientists, technicians who conduct semen analysis. So far, data collection is ongoing, but from the data we have collected, which we have almost reached our sample size, yet to do analysis, but so far, over 95% of the labs do semen analysis wrongly, and the results they present cannot be reliable for diagnosis. Neither can it be for treatment purposes. So whether this was rightly done is another case. Then interpretation of the results too. Then again, the use of clomiphene citrate alone for the treatment. I think I just put this in bold so that we see it very well, because we have seen cases where we abuse clomiphene citrate. The use of clomiphene citrate alone for the treatment of unexplained infertility has not been recommended. This is from Royal College of Obstetrics and Gynecology. They do not recommend in their manual on assessment and treatment of infertility, they do not recommend clomiphene citrate for unexplained infertility. We have seen cases where, because somebody comes with unexplained infertility, we just prescribe Clomid, they keep taking Clomid and nothing happens. So in the diagnosis of unexplained infertility, you rule it out when you confirm ovulation. But sometimes ovulation does not mean the woman is releasing healthy embryos, healthy oocytes rather, as some eggs can be of poor quality. Again, when you rule it out, it's also when you confirm tubal patency. But we also know that patent tubes does not also mean healthy tubes. Sometimes tubes are patent, but the functionality of the tubes are not good. Then semen analysis also. When semen analysis, routine semen analysis, I think I want to use the word routine semen analysis. When routine semen analysis is done and it's normal, that does not also rule out male factor infertility. That's why sometimes we are being careful to tell a man you are fine, and the problem is with the woman. That can lead to marital disharmony, divorce, and the rest. So the fact that the man has routine semen parameters, we should be careful to tell him he's fine, because we do not do what we call sperm function test. Yeah, in some countries, sperm function test has been integrated into routine semen analysis. But where in a country like ours, we still depend on routine semen analysis. Sperm function tests like sperm DNA fragmentation, sperm survival tests, and other sperm function tests should be done. So patient with, we have seen cases where a patient has a routine normal semen analysis, but with high sperm DNA fragmentation or high anti-sperm antibody or very poor sperm survival rate. So when we're telling the man that routine semen analysis is normal, we should also tell him that this does not rule out male factor infertility, as sperm function tests have not been done. In the management, we have expectant management for up to 6 to 12 months. We could still do other investigations, place on antibiotics where you suspect PID or any of the infections. And or since the semen culture yields a particular growth, and all those things while waiting. But you wait when a patient is below 35 years with about 2 years of infertility and with normal ovarian reserve test. You have done ovarian reserve. The first presenter mentioned the constituent of ovarian reserve test, and they are normal. You will want to wait a little. That's when the woman is below 35 years. After 3 years, it is said that 60% will conceive spontaneously, according to a study. And after 5 years, about 80% will conceive spontaneously. But this is when the woman is quite young. In fact, now we don't even talk about 35 years, maybe below 30 years, we will wait for this long. Unfortunately, it is not yet possible to predict which couples will conceive spontaneously or in what time frame. Then you start aggressive therapy when the woman is above 35 years. There's no time to wait, or when infertility is above 3 years. So, and treatment will help to increase the chances of conception, the time to pregnancy, to improve gamete quality. We have patients who are just given antioxidant, gamete quality improved, and spontaneous pregnancy took place. It could also increase gamete number, like patient with mild to moderate oligozoospermia. This will be difficult in severe oligozoospermia, or patient with oligoastenoteratozoospermia. Sometimes it may be difficult, so aggressive treatment may be required. Another form of treatment is expectant management. In couples with unexplained infertility and a good prognosis of natural conception within 1 year, expectant management should be allowed to run for about 6 to 12 months. So sometimes we don't rush to just treat. Patient selection for expectant management is key. Usually patient with good prognosis of natural conception, and the age of the patient, the duration of infertility. A patient coming with infertility above 3 years, you will not want to keep waiting again. We have talked about age is very, very important, especially the woman's age. Even though age has also been found to affect men when it comes to infertility. The older a man becomes, the higher the level of sperm DNA fragmentation. And the cause of infertility too. We have people who already know their problems. Patients who born with, we have adults with undescended testes. So they are born that, we have seen a couple like that, and they have been married for 12 years and gone to places and been placed on medications. The woman has taken cycles of chlormethyl citrate. When they came, let me just examine the man, only to discover the scrotal sac was empty. When I asked, he said that's how he was born. So he was born with undescended testes. So of course you could expect, you know, that they will be azoospermia, and they are counseled for sperm donation, and they eventually agreed for sperm to do sperm donation. So this should guide in tailored expectant management. Then another form of management we have ovarian stimulation. Unfortunately, this is the most abused form of treatment. In most instances, what we see some of our colleagues do is that a couple come with infertility. Sometimes it's just the woman that presents, just as the first presenter said, the women are likely to present first because the pressure of the infertility is more on them. So they come and the attending doctor sees them, just place the woman on clomiphene citrates or on letrozole or any of the ovarian stimulation drugs. You have not seen the man. In fact, I've seen some patients when I ask, when you are placed on this drug, was your husband seen? Especially when I do a semen analysis and see a very bad result. And the woman will say she has taken Clomex, taking it for months. All those people who are taking clomiphene citrate for 6 months, non-stop, as in 6 cycles at the straight. And the man has severe oligosteroteratozoospermia. So when I ask, you say that no, the doctor did not see the man, just placed her on the drugs. So it's the most abused form of treatment, ovarian stimulation. So as much as it is important, applying it, patient selection is key. The wife may be good for ovarian stimulation, but the husband may not be. So a husband with azoospermia and other form of male factor infertility, and you're placing the woman on ovarian stimulation, of course, you are wasting her time. You are wasting her eggs too. Like the patient I just said, she has taken cycles of clomiphene citrates. And by the time while the man is azoospermic, in fact, no testes. So by the time I cancel them for sperm donation, they went and thought over it and agreed, came back to run the woman on ovarian reserve test. Her ovarian reserve was very, very bad. Her AMH was less than 1. Her FSH was very high and all that stuff. So eventually I canceled them for embryo donation. And thank God they did it. She's successful. She's currently pregnant. I think as of yesterday, she was 14 weeks pregnant. So the purpose of ovarian stimulation is to create regular ovulation for patients who have irregular or absent cycles. Ovarian stimulation can also help patients who have regular cycles by encouraging the ovaries to release multiple eggs, which could also increase the odds of multiple gestation. And the type of stimulation also depend on the diagnosis. You know that you give minimal stimulation to a high responder, that's women with PCOS, because you are afraid of ovarian hyperstimulation syndrome. Remember, we had a case and we almost lost the patient. It was struggle for the patient to survive. Somebody stimulated and aggressively, I think, and PCOS patient, and the entire abdomen was full of follicles. So it can be fatal, ovarian hyperstimulation syndrome. The best practice of ovarian stimulation is actually controlled ovarian stimulation with timed coitus. So if you want to do ovarian stimulation, if you can, or you have the knowledge or the skills, controlled ovarian stimulation is the best. And in controlled ovarian stimulation, follicular growth should be monitored by transvaginal scan. So doing it blindly can be dangerous. One, it's likely going to fail. There are women you stimulate, you think you are stimulating, they are not responding, it won't be doing. I remember one of the women I placed on ovarian stimulation, she refused to follow the protocol. She said she was just going to take it blindly like that. She refused transvaginal scan. So after taking it, nothing happened. Then when she came back again, nothing happened. I told her nothing was going to happen. You insisted you are going to take it. So by the time we now did controlled ovarian stimulation, we discovered that she wasn't responding. So the earlier drugs those who have placed her on, of course, was suboptimal. So we have to increase the dose before she responded. So in controlled ovarian stimulation, monitored transvaginally with serial transvaginal scan, followed by ovulation trigger. You can decide to use either a GnRH agonist, commonly we use Lipride, or HCG, human chorionic gonadotropin. You trigger when you have a follicular size of greater than or equal to 18 millimeters. Some people trigger at 16 millimeters. but I think the best will be 18 millimeter. So after which you test for ovulation. Usually when you give a trigger, especially with HSG, even with GnRH agonists, between 36 to 38 hours, the woman should ovulate. An ovulation test can be done using either ovulation test strip. You confirm it with transvaginal scan, where the follicles will no longer be there, they are ruptured, and either progesterone. It's just that our progesterone result is not likely to come out immediately. So here we depend on ovulation test strip and transvaginal scan. Then we have the group 1 ovulation disorder patient, the WHO group 1. Of course, the first presenter said what it is. So how to treat in such a case, lifestyle modification is very, very important for women who are engaged in excess exercise. We have to tell them to normalize the exercise to reduce. Then pulsatile gonadotropin releasing hormone that could be given, poly-GnRH pump, or gonadotropins, like the human menopausal gonadotropin, the HMG, could also be given to them. Then in the class 2, which forms about 85% of the ovulation, the infertility from ovulation disorder, the type 2 forms 85%. And the commonest is the PCOS, the polycystic ovarian syndrome. Of course, the type 2, we know majorly we're talking about the polycystic ovarian syndrome. And the diagnostic criteria, we have the oligo-ovulation or anovulation, the hyperandrogenism, that's what we call the clinical or biochemical hirsutism. Then the polycystic ovaries through transvaginal scan. 2 out of 3 of this is diagnostic of PCOS. The treatment option, we could start from just weight loss, especially in younger ladies. When the woman is like in her 20s, weight loss is very, very important. Sometimes with weight loss, ovulation will resume spontaneously and they will get pregnant. I think I have a patient currently who is pregnant, just PCOS at 20-something, just placed her on weight loss and metformin, and shedded some weight, started ovulating, and she's currently pregnant with no serious form of treatment. So weight loss is very important. The medical treatment, place them on metformin, usually 500 milligrams daily, very important. Then the second line treatment of that is the laparoscopic ovarian drilling. Sometimes we drill the ovary laparoscopically. Then injection of gonadotropin will stimulate, sometimes with intrauterine insemination. Then finally, assisted conception using IVF. Then we have the hyperprolactinemic amenorrhea. Our patients, you see them with hyperprolactinemia. And because of that, menstruation will be difficult. We're seeing patients with very high prolactin, over 150 something with nanogram per deciliter. And that alone could hamper their fertility. Some, the menstruation will no longer be there, or some may be menstruating, but getting pregnant will become difficult. So studies have shown that carbagoline could be used. Usually we use carbagoline and bromocriptine. But studies have proven carbagoline is superior to bromocriptine in reducing the prolactin, the serum prolactin, and in restoring ovulation and pregnancy. So as we can see, the data here presented. And sometimes PCOS could coexist with hyperprolactinemia. Then another form of treatment is IUI. I will dwell a little on this IUI because it's cheap and acceptable by most people. We have people for religious beliefs, they will tell you they want to do IVF, that is against nature. And then, of course, we know the cost of IVF. You can't think IVF with less than ₦1 million. So because of that, yeah, some people tell you can get it in some places, 600, 700, and all those things. It depends actually on the cost of infertility. For where the cost of infertility is strictly tubal factor, that's when the IVF can be cheap. But usually you can't think the journey of IVF with less than ₦1 million. So with that, IUI is also a good option. That's intrauterine insemination. It has been used to treat patients with unexplained infertility, mild endometriosis, mild to moderate male factor infertility. That's mild to moderate oligozoospermia, especially. Mild oligospermia, actually we have the World Health Organization semen, that's andrology manual 2020. The 2010 years is there, but there's a new manual that was launched 2020, even though the launching was postponed because of the, what do we call it now, the COVID-19 lockdown to 2022. 2021, rather, it was eventually done 2021. So it puts oligospermia as sperm count below 16 million per ml. The former value was 15 million per ml. So from 10 to below 16 million per ml is mild oligospermia. So from 5 to less than 10 is moderate oligospermia. So patient with mild to moderate oligospermia, IUI may work for them, especially for moderate semen preparation. Pooled semen preparation is very important. You take 2 or 3 samples, process them, and pool the outcome to a single test tube before you inseminate. Then patient with disability, either physical or psychological disability. One patient who cannot have sex because of disability, spinal injury, and all those things, or one patient with impotency, they are impotent. They cannot have erection. They lost their ability to have erection maybe because of diseases, or they were so born, or one thing or the other. Then conditions that require specific consideration in relation to methods of conception, such as sperm washing for patients with HIV or other diseases that could be transmitted sexually. Then, of course, we know that nobody washes sperm for HIV purposes with the effectiveness of the antiretroviral drugs. Then, as part of donor insemination, we have patients with azoospermia, their husbands are azoospermic, or they have severe oligosteroteratospermia, or they have cryptozoospermia. Well, cryptozoospermia is a condition where you see sperms only on centrifuge. When you see azoospermia, usually you don't just report, you centrifuge the sperm and check the pellets, the semen rather, centrifuge the semen, check the pellets. You may find sperm in the pellets, which we call cryptozoospermia. For patients who insist on having their own children, they could still use the sperm for ICSI. So we have patients who will now come who cannot afford ICSI, or they will now decide to go for sperm donation. This may sound strange in a community like ours, but as I talk to you, it's becoming popular, and in our community, people are beginning to be aware. And as I talk to you, I have patient couple who have opted for sperm donation, and they are ready to do it. So in sperm donation, definitely IUI is a way to go. Then people going for IUI, is also good. We inform them that over 50%, we know that globally the success rate of IUI is about 7.5 to 20%. But there's what we call cumulative success rate. Cumulative success rate can be as high as 60% or even more. So the fact that IUI has low success rate does not mean it should be abandoned. Yes, it has low success rates, but success rates are higher cumulatively, and also higher where the clinical embryologists, where the center that has clinical embryologists. We know that in most of the centers, the semen preparation is not done by a trained clinical embryologist. So when there's poor semen preparation, no matter how much the ovarian stimulation is, the chances of failure will be higher. So we should let patients going for IUI that cumulative pregnancy rate is that over 50% of the women age under 40 years. Age is very important actually in deciding for IUI. 50% of women, over 50% of women age under 40 years will conceive within 6 cycles of IUI. Within 6 cycles of IUI. And after the 6 cycles of IUI, that's of those who do not conceive within the 6 cycles of IUI, about half will do so with a further 6 cycles. That's cumulative pregnancy rates can be over 75%, which is quite impressive. But the question now is how many people will be patient to do IUI for 6 to 12 times? Then the cost effectiveness, the cost of single IUI, and you have to do it 6 times before you get pregnant. So by the time you add up the money, won't you rather consider an IVF But you should also know that the success rate for IVF is also not too good. In a country like ours, it stands at 30% or less, globally around 40%. But cumulative success rate of IVF too is quite good. So we should always let patients know before they start. The reason is so that somebody doesn't go to collect loan. Most of them collect loan or sell a property, raise money that I'm going for IUI, and they think as I pay this amount of money, IUI ranges from 150 to 250,000, depending on the cost of infertility. And the method of stimulation, very, very important. For patients with low ovarian reserve or patient above 35 years or so may require an aggressive stimulation. Some may require stimulation with gonadotropins, FSH. So, and each injection of FSH, I think, is about 12,000 naira or thereabout. And some may receive like 10 to 11 of these injections. So over 100 and something thousand naira on stimulation alone. So we should let them know that the success rate at first trial is quite less, so that they should prepare that I'm likely to go for a second cycle or for a third cycle or thereabout, so that they don't think. Usually when the patient comes, we have a consent form and it's quietly stated. The patient read the consent and understand it very well, so that doesn't think as I pay this money, I'm going to be pregnant. So that when I don't get pregnant, discover there's a problem. Then, yeah, after IUI, I think because of our time, let me just go straight to conventional IVF. That's conventional in vitro fertilization. Yeah, I use the word conventional because ICSI is also an in vitro fertilization. So, but the traditional or the conventional IVF, it was actually invented for tubal factor infertility, but it has been found to be effective in other forms of infertility. So ICSI does not offer any benefits over conventional IVF across different ovarian respondents, that's ovarian response categories in non-male factor infertility. That's for a woman, for a couple whose cause of infertility is not a male factor, going for ICSI does not offer a superior benefit. So conventional IVF is still good. And conventional IVF is quite easy, as you do not necessarily have to be a trained embryologist to do that. A lab scientist with a certificate course in clinical embryology should be able to perform a conventional IVF. It's very, very easy. Then ICSI, that's where it usually has to be a trained clinical embryologist. It was invented majorly for male factor infertility. I think ICSI was invented in 1992 by Palermo et al. So it's gradually replacing conventional IVF because there's an increased number of trained clinical embryologists. So they enjoy doing ICSI. So, and of course, ICSI has high fertilization rates. We know that the first success step in infertility in IVF is fertilization rates. Is fertilization rather. By the time you inseminate the oocyte and there's no fertilization, it's quite discouraging. So ICSI has superior fertilization rates. ICSI can also be garnished with IMSI, that's the intracytoplasmic morphologically selected sperm injection. Here, what is done, ICSI is conducted under a magnification of 40x. So, but in IMSI, the sperm is morphologically selected by attaching a special optics to visualize the sperm at 6,000 times bigger size. That's 6,000 magnification. So you see the sperm so big and you study the morphology. In fact, you use a micrometer to measure the sperms, the head, and to make sure that the sperm you have to pick falls within the normal limits of a normal spermatozoa before you pick it and inject. So that's all about IMSI. And PICSI, that's physiological intracytoplasmic sperm injection. It's just a physiological ICSI. You use hyaluronidase enzyme to select a sperm with good physiological function to inject. So these are just addendum to ICSI, of which their benefits is still being argued, whether they offer a superior success rate to just doing plain ICSI, or they are just a means of increasing the cost of fertility treatment. Of course, by the time you introduce IMSI or ICSI, or PICSI, you can't be charging the patient the same because the equipment for this are very expensive and you want to recover your money. So the patient, they may have higher fertilization rates and implantation rate, but the baby take-home rate is similar with ICSI. And of course, you know that the couple coming to a fertility center, they are concerned with going home with a baby. They are not just concerned with their fertilization rate. They are not concerned with just pregnancy. If the woman tests positive for pregnancy, scan and there's pregnancy and she has a miscarriage, she will still feel bad and feel disappointed. So it's whether she goes home with a baby or not. Then conventional IVF versus ICSI. Of course, I've tried to say the difference, and of course, conventional IVF is just mixing the sperm and the eggs together. Fertilization will still take place naturally in the petri dish, after which you grow the embryo to either a day 3 embryo or to a blastocyst, day 5 or day 6. Then you transfer to the woman's endometrium, for which I would say is quite easy, and lab scientists with just a certificate course in clinical embryology can do that. So, but whether you choose ICSI or IVF, yeah, the question is still there and people are still arguing. But the truth is that studies have proven that the baby take-home rate is the same. In fact, it's superior for conventional IVF, because in conventional IVF, the natural process of fertilization takes place. The sperm swims to fertilize the oocyte itself. But in ICSI, you pick the sperm and put it into the egg. So the possibility of picking a sperm with defective chromosome are high. So it may have high fertilization rate, but pregnancy rate is not superior to IVF. Then we have other forms of treatment. I think this is my last slide. There are many treatment variants for infertility. We have the embryo biopsy for pre-implantation genetic diagnosis, either for sex selection or for mitochondrial donation. We have the 3 parents fertilized conception now, where the sperm and the nucleus of the embryo, the nucleus of the oocyte from the mother, and the cytoplasm of the oocyte is donated by somebody for women with mitochondrial diseases. Then we have for other diagnoses to women with some congenital abnormalities that you want to do a PGD before you transfer. Then we have PESA, that's percutaneous epididymal sperm aspiration. MESA, we know that in azoospermia, we have obstructive and non-obstructive azoospermia. Just like the first presenter said, some infections like vesiculitis or chronic epididymolysis or epididymitis itself can cause obstruction in the ejaculatory duct. So the patient will present with azoospermia. So when we see azoospermia, you have to classify, is it an obstructive or a non-obstructive azoospermia? And what you do that by doing a fructose test. A fructose test is going to show, if fructose test is positive, you know that the testicles are making sperms. It's just that they are not coming out, which is quite easy. You do a PESA, a MESA, and all those things. Oh, but if it's negative, you know that the testes are not even producing sperm. So it's a non-obstructive azoospermia. So you start doing a hormonal assay to check where the problem is from. So we have patients who that is just their problem. They have, the testes are working well, but there's an obstruction. So you do a percutaneous sperm aspiration, that's percutaneous epididymal sperm aspiration, or you do a micro epididymal sperm aspiration, you make an incision, or a testicular extraction, testicular sperm aspiration, or a micro testicular sperm extraction, where samples are taken for either ICSI or for IVF, though not likely for IUI. But the sperms are likely to have high DNA fragmentation. Sperm DNA fragmentation actually occurs in the epididymis. So when sperm has stored there for long, they are likely to undergo damage. Then we'll have treatment for poor ovarian reserve. Yeah, there's a treatment that is still undergoing trial. Some people are doing it with some little success, where they inject the ovaries through ultrasound scan, guide them with platelet-rich plasma. They take the blood of the patient, spin it to take the plasma and inject it into the ovaries, that there could be some form of regeneration, but that is still at the trial stage of treatment. Then we have gamete donation. Of course, in azoospermia, there could be sperm donation. Then in poor ovarian reserve, or patient with primary ovarian failure, or patient with what we call empty follicular syndrome, we stimulate follicles grow, you take the follicles, no eggs are in there, they may benefit from egg donation. Currently, we are, I think, trying to start a research on gamete donation, looking at the acceptability. So whether you can donate your sperm or donate your eggs, or whether you can accept it, if that remains the only way you can have a child. So it's also a form of treatment that is becoming popular in a country like ours. Of course, in developed country, it's a common practice here. Embryo donation, yes, as I told you, I currently have a patient on embryo donation who is pregnant. Then we have surrogacy, womb renting. Yeah, we have people who either born with congenital abnormality of the womb and the eggs are fine. They could do an IVF and somebody helps them carry the baby. Or those who do not or just want to be pregnant and they want to be mothers. Of course, we know that celebrities are doing that, and sports women, they are doing that. They do not want to take time off their sports to go and get pregnant. So, of course, I believe we know what happened to Serena Williams when she went to get pregnant. By the time she came back, it was difficult for her to catch up. So with that, surrogacy is also an option where you either pay, we have commercial surrogacy, where you pay the woman to carry your pregnancy, or the altruistic surrogacy. Then reproductive surgeries, we have tubal procedures, can be opened laparoscopically. Then we have congenital abnormalities where we have can be repaired, like a bisected uterus. That's all those congenital abnormalities where the septum can be resected. Then we have uterine transplants. It's becoming popular. Countries across the world, I think, are doing uterine transplants now. I think the latest was that which was done in India, where the lady had a child through her mother's womb. The mother donated her uterus to her. She got pregnant and had a baby. So herself and her baby were born from the same womb. Then we have stem cell transplant. It's still at a research level, testicular stem cell transplant. And this is of utmost importance to the Arab world. Yeah, in Islam, gamete donation is not accepted generally in Islam. So it's being sponsored. Patients with azoospermia, they tend to non-obstructive azoospermia or primary testicular failure they are trying to talk of testicular stem cell transplant to see if they could start making sperms on their own. Not just Islam, some religions frown at gamete donation. I think Roman Catholics or thereabout, I can't remember very well, but I think I'm sure of Islam. Then fertility preservation, we have ovarian tissue cryopreservation for patients undergoing a gonadotoxic treatment, either cancer chemotherapy or radiotherapy. Then testicular tissue cryopreservation, it's quite difficult. We know that usually there should be sperm freezing before chemotherapy, or men engage in high-risk sports or high-risk work where their testes could be damaged or where spermatogenesis could be affected. They could ejaculate multiple times and the sperms are cryopreserved. Actually, sperms or gametes generally can be cryopreserved for infinite time. The research is yet to tell us for how long where sperms can be kept. They can be kept almost for infinite time. So, but we have children whose testicles have not started forming sperms, undergoing chemotherapy. Either we know the Burkitt's lymphoma and all those things, which are gametotoxic. So testicular tissue cryopreservation is being considered, even though it's still at the research level. Then we have artificial uterus and biobags. Of course, I know we have seen videos on social media circulating on artificial uterus. That is actually coming up, and it's eventually going to be the way to go for most people. Biobags, a sheep has been born through biobags. Then we have posthumous reproduction. Yeah, somebody can actually have a child after death. Yeah, we have a man dies before the corpse is moved to the mortuary. The PESA can be done, sperms aspirated, and cryopreserved. The wife can be inseminated to have a child for the dead man. And sometimes maybe a parent having a business or an investment that he wanted the child to inherit. and now the child is comatose or the child is moribund. So of course, they could take the sperm before the child dies, or the child dies in accident. They could take the sperm and inseminate somebody, either commercially. They could pay a lady to be inseminated to have a child for the dead child, so for the dead son. So we have posthumous reproduction. Then, of course, adoption is also an option of treatment. Sometimes all methods of treatment will fail. We have people who have done IVF several times and it failed, or we have people who cannot even afford IVF. We could counsel them on adoption. And finally, staying childless. Sometimes just counsel them, just take it in good faith. There are advantages in staying childless too. Sometimes we make them know the advantages they have over having children. Sometimes their minds, because of the desire to have a child, they are blinded towards the benefits, the advantages they have by not having a child. So sometimes we open their minds to that. Look at, you can move around, travel the way you want, go for holidays, you can continue your honeymoon without ending and all those stuff. Let them know the advantages too of staying childless. So you live a stress-free life. The stress of having children, you are free from it. So sometimes we let them know. So staying childless is also a method of treatment. So thank you very much. It's my brief presentation.
Thank you, Dr. Nelson, for the elaborate presentation. Please, Dr. Nelson, you can share your screen. Before he share his screen, in order to manage time, please, if you have any question, you put it on the chat box so that we'll reduce the number of people that are going to ask questions, so that will save time. Dr. Bright, please enable me to share my screen. Dr. Bright?
Please go ahead, sir.
Okay. Can you see my screen? Can you see my screen?
Yes, you can see it.
Okay. So the next presentation will be a short one on healthcare team. Everyone is important. And I intend to go in this outline. Teamwork in healthcare system has become essential in today's medical practice. The reason is that there is increase in super specialty, there is increase in technology, there is also increase in comorbidity and multimorbidity. As a result, quite a number of management has to be through teamwork. With the previous presentation, which we have listened, you quite understand that if there is no teamwork, it will not be easy to achieve what has been presented earlier. In Nigeria health system, teamwork is collapsing due to polarization of healthcare workers. We understand that because of the friction among the healthcare workers, the teamwork is not very obvious when it comes to the public health system in Nigeria. It is important healthcare workers understand the importance of teamwork for better health service and to reduce ugly health indices in our country. If there is teamwork, the efficiency of our health service will actually be improved. it has become important that teamwork is now part of training of healthcare workers at various levels, even at the infancy stage, for everybody to understand the importance of teamwork. Then what is a team? A team comprises of 2 or more people that interact dynamically, interdependently, and adaptively. And team is toward a common and valued goal. If we know our common and valued goal, we will know that all this friction that is happening in the healthcare sector will not be there. And we'll have a specific roles and function. Unfortunately, in our health system in Nigeria, roles and function are not clearly defined. And as a result, how people work together becomes difficult. And we should understand that teams have a time-limited membership. It doesn't mean that because there is a composition of team, they work indefinitely. No, the team is actually flexible in modularity and also in scalability. We can see this is a picture of a team. All personnel in all departments of any healthcare facility, and the primary function is actually to deliver health services. Teamwork is not to serve somebody, but it's actually to deliver health services. And patients and our clients are actually at the center of the attention. In the health care team, no one is more important. If at all there's anybody that will be more important, is actually the patient. But what we tend to miss out is that in healthcare team, there have to be a leader. If there is no leader, nobody is going to actually guide the activities of the health team. But that does not mean that because you are a leader of a health team, you become more important than other members of the health team. If we understand this, the friction we are having will not be there. As I said, the center of the team is the patient with other healthcare workers at the periphery. It is important that knowing the duties of other healthcare team members will help you to be more effective team members. Quite a number of times, if at all there is a healthcare team, quite a number of other team members don't understand the work of other team members. Because of that, there will be friction. It will look as if my work is more important than your own. Even we as doctors that are here, it is good for us to know the duties of other team members. That will also guide us in order to carry them along to work. This is the structure of a team. They should have common purpose. Their performance should be toward the directed goals, mutual accountability. Not that when there is a success, it will be attributed to somebody, or when there is a failure, it will be attributed to anybody. No, it will be mutual accountability. There should be clear roles and responsibilities so that everybody knows his own tasks to perform. And skills should be complementary. Nobody knows everything, but everybody will bring his own team in order to improve the services that we render. Then it should be interdependent tasks. So in partnering with patients, which we say that is the most important team members, it is good for us to understand what the patient wants. Unfortunately, a lot of people still practice this paternalistic method of care in which the healthcare worker is seen as a king. But the current practice now is about partnership, which there is an alliance between the patient and the healthcare worker. So it's good for us to understand the problem of the patient, what the patient wants, in order for us to provide evidence-based medicine which is the doctors or healthcare worker expertise, the patient preference, and the current best practices that is available. A team structure, as I said, is about multiple people. It's not about one person. And whenever, according to Louis B. Egan, he said when the ratio of W's to I is the best indicator of development of a team. That is, in team service, every success, it should be about us, not about I. Whenever it is about I, then it is no longer a teamwork. Team is actually not a working group. I see what we are having now is about working group. A group talks about clearly focused leader. That is, everything that is done is about the leader. It's not all about team. And there is individual accountability, individual work produce. Everybody wants to show I'm the best. I'm the one that is accountable for this. We are talking of efficient meeting, indirect measures of performance, and we discuss, decide, and delegate. But in team, there is a shared leadership roles, even though there's somebody that is going to direct. There's mutual accountability, collective work product, problem solving meeting. Anytime there's a problem, the team sit together in order to address it. The essence of a team is actually common commitment. What are the barriers of team performance? Inconsistent team membership. Today, you assemble a team, either a certain person is not there, that becomes an issue. Lack of time, because of perhaps workload or because of reduced number of staff, we are not able to work efficiently. Conflict, which is what is actually bedeviling us in our own health system. And we are being distracted by a lot of things. Workload and also lack of clear rule. There is a conflict. This one say you are the one that's supposed to do this. This one, there is no clear rule. So these are hindrances to team perform. Then in healthcare is continuously evolving. Just as I said, there is increase in technology that most of the things now, technology have to be used. As a result, you require the expertise of other people in order to do it. Some are even non-medical, especially the advent of electronic medical record. You have to depend on a non-medical person in order to work. Preventive care and wellness. Medical care now is shifting toward preventive care. And we have aging population. With aging population, we have multi-morbidity, comorbidity. As a result, you need a lot of teamwork in order to manage. And changing trend of ambulatory care. People want to be cared at home. Of course, one person cannot be able to go and do home care. It has to be a teamwork. So there is now a paradigm shift, even to the team system approach that we are talking about. Paradigm shift from individual to team approach. Apart from the team approach, we are now having multi-team system approach for patient care. That is the current what we are having in the health system now. Multi-team system. Different teams actually come together because of the complexity of healthcare. This is just a model of the structure of multi-team system. Patient is actually at the apex, which I say, if there is a more important person, should actually be the team, followed by the core team, coordinating team, ancillary administration. There are times that we'll have contingency team. This establishes clarity of roles, responsibility that make mutual accountability possible. The core team are actually made up of the primary healthcare providers that work interdependently to manage a set of assigned patient, which is the routine work that we usually do. We say medical team, surgical team bringing other support staff to come and work. These are the core team members that provide primary care to the patient. We have a coordinating team. The coordinating team actually comprises of things like the head of department, the in charges, and other unit heads. They are the ones that coordinate the core teams because they are the ones that will be accountable to the administration. Then we have contingency team. This contingency team are limited time form for emergency or specific event and composed of members from various teams. For instance, during the COVID-19 pandemic, we had a COVID-19 team in facility. These are contingency team. Now, where are they? A lot of them are no longer functioning because COVID-19 is no longer there. So these are contingency team to address a specific issue at a time. The ancillary and supportive service. We know these are the security, the cleaners, the sub-staff. They are equally very important because if they don't do their work well, the core team can actually not work well. If an electrician does not fix the light of a facility, of course, the core team cannot function effectively. Then the administration, as we know, they are the one that establish and communicate vision, hold teams accountable for team performance, and define the culture of the organization. So they direct the vision and mission of the health team. This is just an example of the model to exemplify the multi-team system that we are talking about. As we know, risk reduction is a very common problem associated with elderly people, and this requires multi-team, but interdisciplinary multi-team in order to address it, from ophthalmology, even the structural engineer in designing a facility. So you can see that one person alone will not be able to reduce risk of fall in elderly patients. It requires a lot of hands to be in order to be able to reduce risk. And the administration will hold everybody accountable for the services they offer. As we know, in terms of coordination, is from down up, from the administration, that is the board directors, to the patient. While in terms of responsibility for teamwork is from the patient to the administration. What I've given is just a model, but this is to tell us that the model can be flexible. As I said, in modularity and in scalability depend on the system that we find ourselves. Then what is effective team members? Effective team members understand their roles and responsibility. They are better able to predict the need of other team members. If you don't know the roles and responsibility of other team members, you will not be able to know the needs of other team members. They provide quality information and feedback. Of course, in a team, you need feedback from other team members in order to improve your services. We engage in higher level decision making. We manage conflict. Of course, a multi-team system, because you have brought several individuals and several teams, there will be conflict. So the essence is not to avoid conflict, but is to manage it skillfully, and also to reduce stress on team as a whole through better performance. If every member of the team performs his own work, we will see that stress will be reduced on team members. So achieve a mutual goal through interdependent and adaptive actions. Team action, as I said, from assembling of a team to assemble a leader, identify team goal and vision, assign roles and responsibility, hold team members accountable, actively share information among team members. So you can see that the management is key in assembling and in order for these team members to work. So individual commitment to a group effort, that is what makes a team work, is when every individual commit himself to a group. And this is what will make the teamwork effective and efficient. In conclusion, teamwork is an important health intervention. Healthcare is continuously evolving with changing trends due to technology, preventive care, aging population, and ambulatory care. Clinical care is becoming more complex and specialized. As a result, we require a multi-team system approach. Knowing other team members' responsibility is apt to effective healthcare delivery. Every team member is equally important. This is key. Everybody is important. The person that you think that is least, his work can hamper the work of every member in the team. Teamwork and team training is now seen as an essential part of medical education so that everybody imbibe the spirit of teamwork for efficiency in the health sector. Thank you for listening. So, hello?
Yes, sir, we are listening.
Okay, all right. So we have taken the 3 presentations that we are supposed to take for the day. At this time, we will open the floor for questions and clarification. So please, if you have questions or comments, I will suggest you raise your hand so that we'll be organized in taking the questions. I've not seen any hand yet, but meanwhile, I will give the presenters opportunity to comment on the questions that have been raised so far. So I will give the first presenter, Dr. Mike, to comment on the questions that were put on the chat box before Dr. Vincent and myself, before we have people raise their hand for questions and questions.
The questions that are addressed to the first aspect of the presentations that we've had. I think the first question here says, why is subfertility a preferred term to infertility? Okay, subfertility and infertility are used interchangeably. But some persons may prefer subfertility because the term infertility seems to suggest that the patient's condition may not be amenable to treatment. But when you say subfertility, it means that the patient has, or the client has, a reduced form of fertility. So some persons may prefer to use the term subfertility rather than infertility because of the connotation, that connotation. Okay, then the second question here is, what is responsible for the high infertility in the infertility belts? Okay, so yes, epidemiologically, in terms of what has been found, is the high association of, or the high coexistence of infertility in the region of Africa where fertility rates are also high. Well, this is an epidemiological association, and This infertility belt actually is in sub-Saharan Africa, which is also associated with a lot of other not very palatable statistics. But part of the reason why this is so is because of the fact that in the women who are fertile, there's a tendency towards having a lot of children. And for several reasons. And then there's also low contraceptive uptake in this region too. The contraceptive prevalence rate is low. And so women with who are fertile tend to have a high number of children. For instance, I think Nigeria, the fertility rate is about 6.8%, which is high. And then on the other side, women, there's a high prevalence of sexually transmitted infections and many preventable reproductive problems that could lead to infertility. And so these account for the mix of high prevalence rates of infertility in these regions and this infertility belt where the fertility rates are also very high. So I hope that answers that question. I think those are the questions that are concerned with my presentation. Thank you. So far. Thank you, sir. Can you hear me?
Yes, we can hear you.
Yes.
Thank you very much, Dr. Mike.
Okay.
Okay, over to Dr. Nelson. Dr. Nelson, are you there?
Yeah. So please, can I get my questions? I think my
question, one of your questions.
Yeah, I'm there, sir, I'm here.
Yes, as a way of helping couples with subfertility, especially those staying outside Jalingo, is there any plan to establish specialized fertility clinic in selected health facility in the state, which is one? Then number two, since traditional IVF is relatively simple compared to other methods, why can't it not be done in any of the facility in the state? These are the two questions for you.
Yeah, I think let me start with the second one. Traditional IVF being relatively simple does not mean it's cheap to establish. The cost of establishing an embryology lab, just the embryology lab, not the fertility center, please. Just the lab, because what happens shrine or the fertility there determine whether there's this success rate is going to be good or bad. Alone, it's around 80 million naira. Around 80 million. Thus, this estimate
Hello, Dr. Nelson, are you there? Hello, Dr. Nelson. Hello, are we hearing him? Oh, I'm the only one that is not hearing him.
We are all not hearing him.
We can't hear him.
Okay, I think we have lost him out. Before he comes on board, let me just maybe just answer one of the questions that was thrown at me or was asked. They said teamwork is very important. And there's, but some of the limitations include staff mix, quality of officers employed, training and motivation of staff. So the question is, what are the recommendations that will enable our health facility to promote teamwork in view of the importance of quality of healthcare. From the presentation, you can see that at every level, there are people that are responsible for a certain responsibility. And as you have said, the quality of staff, motivation, of course, this is at the strategic level, is at the level of the management and above. So how to improve it is to employ quality staff and to have a good mix. Of course, if you don't have quality staff and a good mix, the team cannot function well, which I have mentioned it in some of the limitation of team work. So the first thing is for everybody to understand. That is why this curriculum of teamwork is important. It is when people understand the importance of teamwork that will guide us in how we employ and how we mix stuff so that teamwork can actually be effective. So you have mentioned the problem. The recommendation is to address those problems. Once those problems are being addressed, we know that the team efficiency is going to improve. But be as it is, with the current staff and the mix, we can actually improve it because we say skills are complementary. That is why continual medical education is there. We'll continue to train them on the job in order to improve their quality and efficiency so that they can contribute to the team. So it is our responsibility to also retrain the team members so that they become effective and efficient. Is Dr. Nelson back?
Yes, sir.
Okay, I think we lost you along the way. You said the cost of establishing an embryo lab alone is around 80 million. You can take off from there.
Yeah, around 80 million naira. That's an international standard lab with success rate. You are sure of success rate above 40%, in fact, towards 60%, especially with a good clinical embryologist. Then the other one that we could get around maybe 30 million or thereabout, where you get some fabricated equipment fabricated in Nigeria or used equipment. Then that's just an embryology lab, let alone the entire fertility center. The bill of quantity I did 2 years ago, sorry, what do you call it? The proposal I wrote 2 years ago, it was costing towards 200 million naira. So, and that time dollar rate was still around 500 and something naira. Not now that dollar is towards 800 naira. So, yeah, whether a center can be established within the state and all those things, yes, that depends on the government. We don't need multiple centers around because a fertility center requires gynecologists, especially those with fellowship in assisted reproductive technology, and preferable those with masters in reproductive endocrinology, then clinical embryologists, and fertility nurses, and all those things. So you can't be establishing it everywhere. So I think a single center in the state is good enough. So whether we have it now, yes, at government level in Taraba State, not yet. But at the private level, yes, there's a center now in Jalingo where fertility treatment have commenced. We have a center in Jalingo right now. And also, somebody is also asking if there's a treatment for low sperm count. Yes, we do have. It depends on the cause of the low sperm count. If we associate it to a factor, whether occupational, the patient works in the radiology department of the hospital, where it's exposed to radiation, or is drugs, pharmacological, taking some drugs that affect spermatogenesis, some form of antihypertensives, we change them, we switch them, or exercise, some form of exercise, or even clothing, tight clothing that increase testicular temperatures, the person change that, and then generally we give them some antioxidant that has high concentration of or high levels of L-arginine and carnitine. They are good in, they boost spermatogenesis. Vitamin C, selenium, they boost, and zinc tablets, zinc. We have antioxidant that has this combination, especially L-arginine and carnitine. They boost spermatogenesis. So I don't know, I think this is a question, this is a, if I remember very well, I don't know if I've done justice to the question, sir. Hello?
Yes, thank you very much for your response.
Yeah.
Yes, I've not seen any hand up, but I think I'll give this opportunity for anyone that want to make comments or clarification. We have senior colleagues here. I think it would be nice we also hear from them and also learn from their wealth of experience. Okay. I want to believe no one want to make comments or clarification. Hello, are you hearing me?
Yes, I will with you, sir.
Okay, so I want to believe nobody, I can't see.
I raised my hand, though. I raised my hand.
Okay, sir. Okay, sir. So, Chief, so we'll give this opportunity to our CMD, Dr. Alex Miangwa, consultant gynecologist.
Yes. Thank you very much, the three presenters. I think you guys did wonderfully well. And like the moderator said, honestly, infertility or subfertility, however you call it, it's a complex topic because it can go any direction, really. And I was so happy the way it was approached from Dr. Mike Nelson and the team approach also by the moderator, which is very good. In fact, I started listening from the beginning, but distractions here and there, you know how it is with Zoom presentations. But I had just a few comments to make. Mine are just comments. In fact, when the second presenter was talking about laparoscopy and the investigation, it is very, very true. One has to be very careful and also very sensitive because we have had cases of infertility. If the clinician does not handle it very well, honestly, you don't follow these patients back home and you can just ruin their marriages if you just, you know, approach it lackadaisically. I remember during residency, a woman actually came to me and was like in tears, you know, that she's one of our patients then. In fact, they stay in a compound. The mother-in-law is always insulting her. If she goes to fetch water in the well, she's always on her case. Why are you fetching water? Leave women that have babies, all these kind of things. So there's a lot of psychological issues with it also. And the sad part is that we don't really do the barrage of investigations and get definitive diagnosis. Like one of the presenters mentioned, you just do a few investigations and then you now proclaim that there's no problem, especially with the man. And we have seen how some of the SFAs really, you cannot even trust some of the results you get. That's just the truth. You can run the test in one lab. That same lab, probably the same sample the next day, you get an entirely different story. And then I also remember laparoscopy. We used to do a lot of laparoscopies before. Patient comes, it's a very vital part of investigation for infertility, especially in our environment. You know, our own case is tubal factor infertility, or like the Western world. It's still like that up to now. As part of our fertility workup in those days, we do laparoscopy. I have done so many laparoscopies those days. You do the laparoscopy, the tubes look okay outside, you know, the pelvis looks not that bad. Then by the time you turn the laparoscope and you look under, you direct it towards under the liver, you now just see that violin like Fitzhugh-Curtis kind of thing, perihepatitis. That's Fitzhugh-Curtis syndrome, usually due to chlamydia in this area, and it just changes the whole story. Because one of the speakers, if I remember, mentioned that the tube might look okay, but the intima might be another thing else. Now that will now throw your direction somewhere else. So you need to actually be very careful. And some of these investigations, we don't do them, So it becomes difficult to get the clear picture of things. And then I remember also IUIs, we used to do it in Jos. In fact, a private setup. Those of us that know Professor Tubu, we used to go and do shop there, You have patients coming. I remember a particular couple, they came all the way from cross rivers, from Port Harcourt to come and do IUI, and we use donor sperms. We do the insemination, and we used to have success rates. Once in a while, we're lucky, and the lady takes it. Usually it's male factor infertility. They move away. You don't want to do it in your locality. You know about confidentiality is an issue, So they traveled all this distance and came to Jos. By the time we did a couple of sessions, they actually took him. They had to go back and I think she had a CS, if I can remember, and delivered. But of course, it was strictly confidential. It was donated sperm, those kind of things. So it involves a lot. And the patients spend a lot of money. They spend and spend and spend. So we really have to put that into context again. Like Dr. Nelson said, one of the presenters, you don't waste their time and waste their money, If you cannot handle some of these cases, just refer. Have a linkage with a centers that are into this thing. Really, we should have specialized centers now for infertility, not wasting patients' investigations left, right, and center. They come and tell you they have done everything. By the time you look, you see something else. So, and one of the presenters said, advantages of staying childless. If we start telling this one to our patients in Africa here, they will not come back home. Which is true. Probably it's something to look into, but one has to be careful because we know in our own environment, there's a lot of premium placed on marriages that produce children. That's the whole issue now, So when the couple come to you and you're telling them the advantages of staying childless, I'll tell you, for them coming back again to see you by that issue. But it's also, I think, an area we have to start looking into here. But don't forget the environment where we stay, the locality, tradition actually plays a part. So these are just a few things I picked up here and there, but by and large, I think it was a wonderful presentation by all the speakers. Thank you very much, moderator. I think that's all I have to say.
Okay. Thank you, our CMD, for insightful contribution. Is there any other contribution? Is there any more? Okay. In the absence of any other contribution, Dr. Ede, you want to say something?
No.
Okay, all right. So we'll take announcements, then we'll now close. So the CME program continues tomorrow at 9 a.m. at the doctor's house. And registration continue for those that were not able to register before now. They can still go ahead and register. We were generous enough to allow the link so that those that can register late can come and register. Actually, it's only those that register that will be provided with CME certificate. This is 10 CME certificate for the 5,000. So please, I encourage those that have not registered to register. So in the absence of any other comment, I want to thank everybody for attending this CME session. I hope that we'll meet tomorrow for continuation. Thank you and have a blessed day.
Thank you, sir.
Thank you, sir. Hmm?